Obesity, osteoporosis, are you going to add a stem or not? So we need to know what we're talking about, and obviously there are different grades of obesity. There's now also a super morbid obesity category, which is over 50, but there wasn't enough space on the slide for that picture. In terms of osteoporosis, we know it's the 2.5 standard deviations below the mean. But one of the things just to mention at the start is that most of the studies that I'll talk about don't talk about the patient's alignment, and most of the obesity studies don't actually measure whether the patient was osteoporotic or not. So if we have a look at this, we need to get into this world of bone mineral density, and we've heard some other very good talks about that. But essentially, we know that osteoporosis does correlate with fracture risk and that sort of thing, particularly in women, particularly in the arthroplasty age group. If we're starting to talk about stems on knee replacements, we're doing it because of enhanced support, because of either poor foundations or extra loading. You do need to be aware that lots of different implants have got different stem lengths on their normal implant. So in our department, we have the two primaries on the left, and the one, the Genesis 2, has a much longer tibial stem. So you get a bit more of a extra stem just by using that versus the triathlon. But some of the studies are looking, for example, with that next gen, where they're talking about a proper extra 30 millimeter stubby stem. So if we look at studies like this particular one, I think, heightened a lot of the concerns that people had, where basically they said, even when the BMI cutoff was 30, they noticed a substantial benefit to reducing loosening rate by having a stem on the tibial side. In contrast to that, this particular paper said they found no difference. And part of the problem we've got is that almost all of these studies are cohort retrospective studies where they've said, we did 200 knees, 50 of them we used a stem, we had a look at their BMI, and we couldn't see a difference. But none of that stratifies for why the surgeon chose to use a stem for that particular patient. So these are the other papers that talk about it. One or two show some increased problems with stems. Most of them are poor quality retrospective cohorts. So they give an idea, but they're not really scientific. If we look at this one, they essentially showed not a big difference, but one of the interesting things that they noted at the end with the patients above BMI of 40 was that if they were left in varus alignment, then that was a problem and correlated with loosening, revision, and return to theatre. So this was one of the first ones that started introducing the concept of alignment, not just porosis or obesity. And obviously there are different soft tissue envelopes around the knee, and we've spoken about this before. But certainly if you've got a really big obese knee, technically it's more difficult to have good cementation. Technically it's more difficult to get your alignment right. So what about osteoporosis? We've heard some talks on this already in this meeting, but as you start going into it, this is one of the things that I've been picking up is maybe I should be treating more of my patients with bisphosphonates, getting the rheumatologists involved more, because there are a couple of studies out there showing that actually using bisphosphonates in this group of patients can reduce their loosening and fracture risk. There's also this good review looking at the whole concept of bone mineral density and fracture risk if you wanted to go and have a look at it. So essentially one of the issues is, what are you going to do in theatre or in planning for your patient? And I think one of the key things is to preoperatively risk assess the patient. So are they osteoporotic? What is their weight? I think it's important to assess their alignment, but probably also this concept of how much are you going to change their alignment from what they were before? Because just because someone's big, they've been walking on their knee, and that bone with Wolff's law will have become stronger and more sclerotic. So the bone is used to taking that load, but it's when you shift their alignment, you move their weight onto bits of bone that aren't used to taking that load. So I think often you do need to have options available in the theatre with you. But this is an example to try and make that point. This was a valgus knee, and the lateral condyle here doesn't look too bad, but the medial condyle, once you've lavaged it, is very porotic. And so I think it's quite useful, even though it's not very scientific, but if you can push your finger into the bone, it's not strong enough to take the patient's weight. So you then need to inject more cement into these areas or have another strategy for supporting it. So in terms of some tips and tricks, what I'd suggest is once you've done your femoral cut through your jig, if you re-skim just leaning slightly on the jig, so that when you're putting your trial on, it goes on more easily rather than having to really hit it on, then that makes it a bit easier. In this group of patients, you definitely don't want to notch the femur. On the tibial side, don't undersize. Have your implant sitting properly on cortical rim. And if you've got a system that has an anatomical tibia, that's probably better for giving you a rim fit all the way around. I inject cement fully in the stems of the normal implant and into any of those borderline areas. But certainly as the risk that you've identified goes up, you need to have more options available. In terms of the other tips and tricks, fully cementing the stem, but you can also inject cement up the intramedullary canal and into the condyle that has more dubious bone. But I think the main thing is you've just got to be aware of the cases that might be a problem. So this one just doesn't look like a standard osteoarthritic knee. So you need to have your sensors on alert, and you don't want to find out that for the first time in theatre. So being aware of them, because certainly in that case, you'll need to have some other strategy, and you're definitely going to put stems on a case like that. In this case here, we've got a patient who's predominantly patellofemoral, but also lateral. They're already a bit notched because of the patellofemoral disease. This one here, the postoperative x-ray, it does look as though they've been put in a little bit too much valgus on the distal femoral cut. And so as you watch that over time, it does what you expect it to do, which is drift off into the soft bone because technically the alignment was not good in theatre. Another case here, this one, these are x-rays from a couple of months before, and she comes up now in a wheelchair, can't walk. And so you do need to be aware that these sorts of patients do get osteoporotic stress fractures, particularly with their more extreme valgus. And obviously in a case like this, you are going to use a stem, you're going to reinforce it and bridge it as well. In this sort of patient here, so they're in the risk age group for being a bit osteoporotic. They are lateral, so I'm a bit worried this might be a bit porotic. This was done by one of my residents when I was away, and I looked at the post-op x-rays and I was pretty happy. I thought he'd done a good job. But then what we saw when she was back in clinic at about 2 months afterwards, she reported increasing pain. And you can see that both the tibia and the femur have collapsed into the soft medial bone. So she was heavy, she had sclerotic lateral bone, he's got her perfectly straight, so now she's loading her bad bone. So think about the alignment correction at the same time. So in summary, there's no clear evidence for obesity itself being the only problem with using a stem or not, but it's probably more to do with the alignment, and if you're changing their alignment, that you need extra support. We know that osteoporosis is definitely related to loosening and fracture and subsidence. You need to preemptively screen that. You need to have some intra-op options available, but use some of those standard tips and tricks in theatre, puts less stress on the bone, less likely that you cause intraoperative fractures. And I think it's probably that combination of porosis and alignment issues, maybe with a bit of the loading from obesity, that's what you need to watch out for. Thank you.